Hey, it's Tim from ChiroUp, and today we're going to go over a practical foot and ankle exam. There's a lot to cover in a foot and ankle exam, but we'll go over the basics and then I'll show you ways that you can dive deeper into any one of these. The first thing that we're going to do is we're going to look at the patient's foot. We want some inspection. For the inspection, is there any deformity of the foot? The big one that we'd look for is there a bunion? Is there an acute angulation of this first digit? We're also going to look, is there any unusual angulation of any of the other bones or toes? A lot of times we'll see a hammer toe where the proximal interphalangeal joint is bent, or a mallet toe where the distal interphalangeal joint is bent. Sometimes we have a claw toe where they're both bent, and usually that's more systemic. We'll also look at the foot arch height when it's unloaded. Is it a pes cavus where there's a high arch, or is it a pes planus where it's fallen without weight? Later on we'll talk about what happens when we load that, but for now just taking a peek at it. Also take a quick look at which toe is longest. Most patients' great toe is longest. In about a fourth the population, their second toe is longest, and that's called a Morton's foot. That's going to put more stress on that second metatarsal. While we're looking at the foot, we're looking for any signs of swelling. Is there swelling around the ankle, swelling over any of the bony prominences, or on the underside of the foot? Are there any color changes? Especially if there's been any bony damage or ligamentous damage, it's going to bleed. That can take hours to days to come to the surface, and then gravity is going to cause that to fall in whatever direction gravity is pushing it. Most of the time downward, since the patient is dependent. So we'll see some bruising, usually inferior to where that's happening. We'll also look for any signs of infection. Is there any redness in the area? And are there any trophic changes? Is there a lack of hair? Is there a lack of blood supply to the area? Just like we see in patients who have carpal tunnel syndrome often have nail changes. Patients who have vascular issues in their foot often have nail changes as well. We'll look for any scars or ulcers, things that could change gait, or things that have told us about a prior injury, and any calluses on the foot. Are there signs that the foot is starting to wear in certain places with more stress? While we're speaking of calluses, don't forget to check out that patient's shoes, because that's where we're going to see wear patterns as well. If there's somebody who has hypersupination and wears on the lateral aspect of the foot, or hyperpronation and wears out the medial aspect of that foot, we want to see that. The next thing that we'll dive into is the range of motion. We're looking for the ankle plantar flexion to be able to be about 50 degrees, both actively and passively, and dorsiflexion is usually going to be about 20 degrees. We'll say that ankle inversion is 30 to 35 degrees, and ankle eversion is going to be about 20 to 25 degrees. We'll also check out how each of the toes move, paying special attention to the great toe, that we want to take that back and say, is there the ability for that great toe to dorsiflex? Or is there some sign of hallux rigidus along the way? We'll also look at the resisted movements of especially a few different muscles. We can test the gastroc and soleus by having that patient walk. That's an easy way to do it. If the patient can't walk, we can have them flip onto their stomach, squeeze their calf, and what we should see is that their ankle plantar flexes. If nothing happens when we squeeze their calf with Hoffman's sign, we're seeing that there could be a rupture of that calf, the gastroc or the soleus, and the Achilles tendon. The tibialis anterior, that's the muscle that helps to support the arch, so it inverts and dorsiflexes the ankle. We have the patient hold that position and then resist us trying to do just the opposite, to test the tibialis anterior. To test the peroneal muscles, which are often irritated in this posterior channel, they're just the opposite. Those are muscles that are going to take the foot down and out, and so we're going to have that patient resist us pushing back up and in for the peroneal muscles. And finally, the posterior tibialis, which takes the foot into this direction, and again we're trying to push out and up in that instance. The last thing that we do resisted-wise on our patients, especially if they have some heel pain, is say, can they abduct their toes? So spread all your toes, and if this little toe is not able to abduct, it tells us there's weakness of the abductor digiti minimi, which tells us there's probably some irritation to Baxter's nerve as opposed to plantar fasciitis. Now, palpation-wise of the foot, there's lots of stuff to palpate. There are 26 or more bones in the foot and ankle complex. So out of those, things go wrong. The things that we're most concerned about is the lateral malleolus. Is there tenderness over the lateral malleolus? If so, that could be a fracture. Just inferior to the lateral malleolus, those are the ligaments that hold that ankle together, and there's often tenderness, especially at this one, the anterior talofibular ligament. We'll go just back behind the ankle onto the peroneal tendons and say, is there any irritation there for peroneal tendinopathy? And back even a little further onto the Achilles, especially in the mid portion of the Achilles for a non-insertional Achilles tendinopathy, or down onto the heel itself for an insertional Achilles tendinopathy. While we're back here, we're also palpating, is there any retrocalcaneal bursitis? And in a young person, do they have any irritation over that tendon? That's probably not insertional Achilles tendinopathy. That's Seaver's disease, which is an apophysitis where the Achilles tendon is pulling off of that bone. As we come down the foot, we can palpate the cuboid, which is just proximal to the fifth metatarsal head, and say, is there any tenderness in the cuboid? That would tell us, is there a cuboid fracture or potentially cuboid syndrome? We'll also palpate the head of the fifth metatarsal, and that's going to tell us, is there a potential fracture, which is a common site of fracture, or could there be a traction apophysitis? In this case, in a young person, it would be Eislin's disease, which is traction apophysitis of the peroneus brevis. As we come toward the top of the foot, we'll palpate in between the metatarsals, especially in between the third and fourth metatarsal. That's a common location where we'll see a Morton's neuroma. The way that we can ramp up our palpation of this is with the lateral squeeze test, squeezing that patient's foot. If there's an irritated nerve in there, it's not going to appreciate that. If they have pain on the top of the foot, it could be a tendinopathy, or it could be a stress fracture, that if we have some irritation, especially this second metatarsal is a common area for stress fractures along the way. As we come up, we take a look at the tibio-talar joint. Is there any tenderness there? We could have an impingement syndrome, or we could have an osteochondral lesion, or even a fracture. As we drop toward the medial side of the ankle, once again we'll palpate the medial malleolus. Is there a potential for fracture there? There's also the possibility of some irritation to the tendons behind that medial malleolus, which would be a posterior tibial tendinopathy in the area. We could also have tarsal tunnel, because remember that posterior tibial nerve wraps down and then supplies the foot. So if there's some irritation and neurologic symptoms back in that area, we could have tarsal tunnel syndrome. The other thing that we talked about a minute ago was Baxter's neuropathy. A branch of that posterior tibial nerve called the lateral plantar nerve travels down and onto the foot and supplies the underside of the foot. It often has irritation in this area, and if so, it's going to mimic plantar fasciitis. So we'll palpate this, especially in our patients who we think might have plantar fasciitis. And then we come down into the navicular to palpate the navicular deeply. That could be fracture, or it could be Kohler's disease, which is pediatric avascular necrosis of that bone. As we go toward the undersurface of the foot, if there is any irritation just below the great toe, we could have sesamoiditis. And then we're looking for this arch here for all the metatarsal heads, palpating those metatarsal heads for metatarsalgia. Most significantly in the foot, most pain is going to involve the heel. Could be heel pad syndrome. If we push over the heel, if you feel a thinning, that should be about a 2 centimeter thick fat pad here. Sometimes it feels thin and wimpy, and in that case the calcaneus is taking more stress with each step, and we're going to have irritation. Most commonly, it's plantar fasciitis, where this big thick band of tissue runs off of the toes onto the heel, especially the medial aspect of the heel. That patient who has tenderness in that area when they get up the first couple of steps in the morning oftentimes has plantar fasciitis. So speaking of plantar fasciitis, what are we going to do? Well, our number one test is what happens when you bear weight. When we have that patient go ahead and stand up, do they have pain? So the first time they stand up after they've been sitting or lying down for a period of time, it's going to be uncomfortable. And Braden, if you could face this way for a second here, that's going to probably be uncomfortable those first couple of steps, then it'll fade. One thing that we can do to help differentiate between plantar fasciitis and somebody who has a Baxter's neuropathy, or somebody who has a heel pad syndrome or a calcaneal stress fracture, is have them walk on their toes. So when they step up, what's happening here is you're engaging the windlass mechanism, that if you have plantar fasciitis, that's going to hurt. If you have heel pad syndrome or a calcaneal stress fracture, it's going to feel better because you're unloading those sensitive tissues. What we can do to ramp that up is to either take up the patient's great toe, which is the great toe dorsiflexion sign, and does that amplify their pain, or take up all of their toes, which is the windlass sign. So if that patient says, yes, that hurts more when we move them into that dorsiflexion of all the toes, that's probably plantar fasciitis. The next thing, Braden, if you lay down for a minute, we'll talk about ankle sprains. That's probably one of the next more common things that we're going to see. We'll stress test each of the ligaments in the ankle. That if we expect a lateral ankle injury, most of the time that involves this anterior talofibular ligament, we're simply going to move the foot into some degree of inversion to stress those. We're looking for pain or laxity or any unusual sensation compared to side to side. The other test that we'll do is an eversion stress test, where I'm going to take the patient's ankle, in this case testing that big thick deltoid ligament, which is not injured as easily, but stressing the foot into some degree of eversion. We'll also do an anterior drawer, which we grasp the patient's distal tibia and fibula and pull forward. We're looking for, does that feel like a drawer where it shifts different from side to side, and a posterior drawer where we're taking that backwards, if there's any laxity in the area. The other thing that we can think about is a high ankle sprain, and a high ankle sprain involves a syndesmosis between the tibia and the fibula. So if we can spread that, that's going to be uncomfortable. A couple of things that we can do is when we take the foot into dorsiflexion, we're jamming that calcaneus up, or the talus rather, up in between those two bones, spreading them out. And if we add a little bit of external rotation to that, now we're really spreading those bones, and the syndesmosis is not going to like that. The other test that we can do is a fibular squeeze. Think of these two bones as two dowel pins. If I squeeze them in the middle, they're going to kind of splay at the end. So if I do a fibular squeeze test, sometimes that's going to recreate pain at the ankle. If this recreates pain at the ankle, a firm squeeze, that tells us there's probably a high ankle sprain. And the patient can do that by themselves as well. We can have them get into a figure 4 position, cross their knee at their shin at their knee, and then push down. And when they're pushing down on their own thigh, if that's uncomfortable, then that cross-legged sign tells us there's a high likelihood of a high ankle sprain. As we're palpating that area, the longer the distance of the tenderness in that syndesmosis, generally the worse the injury. Now for tarsal tunnel syndrome, this is our patient who has some numbness and tingling onto the bottom of their foot, potentially some pain. The dorsiflexion eversion test stretches that nerve. It's much like Phelan's test for carpal tunnel syndrome. So as we take them into dorsiflexion and eversion, that's going to be some numbness and tingling. The most sensitive test for tarsal tunnel syndrome is that plus manual compression. And we call that the triple compression test. So doing all that together has a high likelihood of causing greater ischemia in that posterior tibia, in the posterior tibial nerve, and the accompanying tarsal tunnel syndrome that goes with it. Now lastly, the thing that we're going to want to do is to assess the function of the patient. So Braden, if you stand up one more time, we're going to have that patient stand first of all and say, what does their foot look like? We're looking for the too many toes sign. That ideally, if a foot does not have any degree of hyperpronation, it's going to line up real nicely forward. We're only going to see the lateral 1 or 2 digits. If we see that patient has a lot more digits, that tells us the arch is probably falling down. We'll also see a bowing of the Achilles tendon here. So those are two signs that kind of give away some hyperpronation. The other one is, what's the arch look like? That can I get my fingers underneath that patient's arch? The thing that I like to do is to assess the patient's gait. So we'll get out our camera, put it on slow motion, watch them walk barefoot up and down the hall. That accentuates a whole lot of things that we might see. Are they landing with inversion, eversion, supination, pronation? What happens to the arch in particular when they're walking? Does that arch go away? If so, we need to give that patient some strengthening exercises for the tibialis anterior, for the intrinsic muscles of the foot, and potentially arch supports or even custom orthotics. The other thing that we'll want to look at is what happens when that patient has to use their hips to stabilize their lower extremity. So Braden, if you face this way, we're going to have that patient, first of all, stand on one leg. And what we're looking for is what happens to his belt. Does it stay level or does it tip down? If it tips down off to the side, it tells us that this gluteus medius, which attaches the hip crest to the acetabulum, is not strong. If this muscle is tight, it's going to pull him back up level. If it's weak, it's going to let him fall to the side. Then we're going to say, what happens when you stand on one leg and you squat down? So when you squat down, does his knee come straight at you? Does he compensate by leaning towards me? Or is he able to stay straight up and let that knee come straight at you? Or when he squats, does his knee dive inward? If his knee's diving inward, that means this spring, the gluteus medius, is weak, because if it were strong, it would pull his knee back out again. So when this tightens up, his knee comes out. That strength of the area will give us an idea of what happens when the patient challenges that walking throughout the day, because most of the time, if you have a problem with the foot, you also have a problem with the gluteus medius. These are two biomechanical co-conspirators that always go together. The other thing that we'll look at is, what are the leg lengths? Is there any leg length discrepancy between the two? Having that patient lying on their stomach again and saying which direction do things go. And Braden, if you want to lay down one more time. The last thing that we'll do, and you can go onto your back too, is we're going to check the dermatomes and the myotomes and the reflexes. Now the myotomes we checked with our resisted motion. With the dermatomes, the foot has a complex innervation. So you can take a look at the chart of that, but say, is there any difference to sensation to gross touch or a pinwheel in the area? And then the reflexes for the lower extremity, we're looking at the patellar and the Achilles reflex along the way. Don't forget a quick vascular evaluation, that what's the dorsalis pedis, and also what is the posterior tibial pulse. And don't forget, it's the posterior tibial, not the posterior fibular. So we put our finger back here to say what's that pulse. And finally, on capillary refill, when I squeeze his toe, does it refill within about 2 seconds, which is what we're looking for. And finally, if there's any suspicion of a lumbar radiculopathy, we can do a straight leg raise. We can do a Bragard's test to say, does that reproduce the patient's symptoms along the way? I hope that this information has been helpful in your foot and ankle exam. If you'd like to look deeper at any of the conditions that we talked about or any of the tests, then you can dive into Chiro Up underneath the condition reference or the assessment tab. Thanks for watching. I look forward to hearing from you in the future.